Hi, I'm Conrad Fisher, and this is Endocrinology. Now, endocrinology, let us see, Chapter 7, Let's Control Our Calcium. Well, have you ever heard that the majority of calcium in your body is in your bones? Yeah, I think you have. Well, 99% of your calcium content is inside the bones. Well, that means that what we're playing with inside free plasma is a simple 1%. A simple 1%. 1% is all we're playing with inside that body. Wow. Well, the interesting thing is, of that 1% that's inside the body, about half of it is protein bound. Half of it's protein bound. So that means there's a tiny, tiny, tiny amount that's actually free. Look at this. This is the amount of free. This is what that's saying. Only about a tiny 1/2% is actually free in calcium. Oh my goodness. Only 1/2 or 1%. Now the most important thing for us to learn first is that half the questions on calcium is going to be how does the body regulate and maintain free calcium? What changes albumin binding? What changes binding to the buffers? What changes binding to citrate and phosphate buffers? Why do we have phosphate? Phosphate is there to fine-tune the calcium, to dial up and down the calcium a tiny bit. We dial up and down the phosphate. So phosphate is there largely to buffer up and down the free calcium. Citrate is there. Citrate's an important buffer. It's the same thing that we put in a blood donation. See, how is it that we keep a blood donation from clotting off? We put citrate as a buffer in there to keep it from clotting off. Woo! So most of the protein in the body, most of the calcium in the body is somewhere between free and buffered. About 45% of it, 45% of it's going to be protein bound. 15% or so is going to be onto these buffers, phosphate and citrate. And how do we dial up and down the free? Why this is important is because, in fact, it's only the free calcium that participates in biological processes. That's the same with everything else in endocrinology. It's only the free that has its clinical effect. Now, the free calcium is what's active. The free calcium is what has feedback inhibition on the parathyroids. The free calcium is what has a tissue effect. Now, alkalosis, well, not just from hyperventilation, but that's one good example, changes the protein binding of calcium up and down. When you have alkalosis, the body fixes the alkalosis by taking hydrogen ions off of the cells of the albumin. The body takes acid off of protein and puts calcium on. Hydrogen ions is a cation. Calcium is a double cation, a divalent cation. You like that, my universal cation sign? So alkalosis causes you to lose free calcium. Acidosis increases free calcium. Now, when you have calcium, you want to make sure you don't have too little because you'll seize. You don't want too much because you get constipated and lethargic. How do we keep that free calcium in just the right amount? Goldilocks and the three calciums. So calcium and phosphate are together laid down in bone. If you have the phosphate stay the same and the calcium goes up, bone will be produced. If you have the calcium the same and the phosphate goes up, bone will be produced. If you have one or the other go down, bone will be resorbed. Now, if bone is reabsorbed and I release a calcium and a phosphate, and I urinate out the phosphate and retain the calcium, bone will continue to be dissolved. And I take out a calcium and a phosphate, excrete the phosphate. I take out a calcium and a phosphate, excrete the phosphate. And that's how I keep that calcium level up. That's a kind of a solubility product. And that solubility product is what keeps my calcium level normal. The solubility product. Now, this thing here with the nice S-shaped curve says that when my calcium level is low, PTH is going to be high. And when my calcium level is high, PTH is going to be low. That's a way of saying high calciums inhibit PTH, low calciums stimulate PTH. There's only one feedback inhibition on parathyroid hormone, and that is calcium. A decrease in free calcium will increase the parathyroid hormone. When you increase the parathyroid hormone, you will dissolve bone. PTH dissolves bone. PTH will increase kidney absorption of calcium. PTH will activate vitamin D. PTH dissolves bone. PTH reabsorbs calcium from the kidney. PTH activates vitamin D. And that's how we keep our calcium up. You like that? Some are fast, some are slow. I like that. Well, the ones that happen fast is kidney happens fast. Bone slow. Slow bone, fast from the kidney. I'm fast to get pissed off, but I'm slow to get boned. Now, the rapid action of PTH. The PTH makes the calcium go up. Why? Because it makes the distal tubule reabsorb calcium and excrete phosphate. Well, here it says decreases phosphate reabsorption. Well, what's the difference between saying excrete phosphate or decrease reabsorption? Excrete phosphate, decrease reabsorption. Excrete phosphate, decreased reabsorption, same thing. Now, it's not going to be good enough for you to just say PTH does thing in kidney. PTH does thing in kidney. PTH does thing kidney. You're going to have to know that PTH increases calcium reabsorption in the distal tubule, the same place that hydrochlorothiazide works in terms of its antihypertensive effect. Where the PTH works in the kidney is the same place. Where the PTH works in the kidney is the same place that hydrochlorothiazide works in the kidney, which is distal tubule. Distal tubule. Now, phosphate is filtered at the glomerulus and excreted, or I should say decreased reabsorption, in the proximal tubule. Phosphate reabsorption is in the proximal tubule. Phosphate, proximal. Phosphate, proximal. Calcium, distal. Now, what also happens is that when you reabsorb these ions from bone, only one stays in the blood. Bone gives up calcium and phosphate. But the kidney only retains the calcium under the effect of hyperparathyroidism or parathyroid hormone. The bone dissolves and makes a calcium and a phosphate, and the kidney excretes the phosphate and retains the calcium. Now, this is the slow effect of PTH at the bone. PTH at the bone will dissolve that bone and release calcium and phosphate. At the same time, vitamin D at pathologically increased amounts, vitamin D at pathologically increased amounts will also dissolve bone. At normal amounts, vitamin D is a gut hormone. At normal amounts, vitamin D is a GI hormone. At normal amounts, vitamin D is a gut hormone. But when you have pathologically increased amounts, vitamin D will eat up bone. It's like a cannibal, man. At normal amounts, vitamin D will not touch the bone. But at pathologically increased amounts, vitamin D will destroy bone. Okay. Now what about this calcitonin stuff? Calcitonin is a hormone that under normal conditions, we don't really know what it does. Calcitonin is like the bumpers on your car. Under normal driving conditions, you don't need it and you wouldn't notice that they were missing. Calcitonin is like bumpers on your car. It's only there when there's something bad going on. When the calcium level goes pathologically high, calcitonin will instantly shut off osteoclasts to correct the calcium. Under normal conditions of calcium, calcitonin will do nothing. That's why calcitonin deficiency has never been described. And calcitonin excess, although calcitonin can be a marker for certain cancers of the thyroid, medullary carcinoma of the thyroid, although calcitonin can be a marker for certain tumors, a pathologically increased amount has never been described. PTH activates the osteoclasts. And since it activates the osteoclasts, what happens with PTH is it dissolves bone. PTH makes vitamin D. Now, vitamin D has its effect, although it is formed in the proximal tubules. The major effect of vitamin D is at the intestine. You see this? Intestine. Vitamin D may be formed in the kidney, but it's active in the gut. Calcitonin, a peptide hormone made in the parafollicular cells of the thyroid. It only has its effect in response, you see this, to elevated calcium. When the calcium level is normal, you won't notice that you're deficient in calcitonin. Calcitonin, on the other hand, can be used therapeutically for things like osteoporosis. Your 65-year-old mother who's got osteoporosis, so you're worried about it. Little calcitonin nasal spray. Very nice, very nice. Little calcitonin nasal spray. How nice. Calcitonin can also be used for Paget's disease. Paget's disease of the bone, that is. Calcitonin inhibits osteoclasts, stops the destruction of bone. Very nice, very nice. See where it says calcitonin is not a major parathyroid-related peptide. Parathyroid-related peptide is what you get from cancer. Parathyroid hormone-related peptide. In other words, which cancer can give hypercalcemia? The answer is all of them. Parathyroid hormone-related peptide is something that you get with anybody who has any hypercalcemia. It's the hypercalcemia of malignancy. It's the hypercalcemia of malignancy. The hypercalcemia of malignancy is from parathyroid hormone-related peptide. You don't measure the parathyroid hormone-related peptide. You measure the calcium level and say, hey, you got cancer? You must have this. Paracrine. Endocrine means it goes into the bloodstream. Exocrine means it goes into a duct. Paracrine means it's around or near an organ. In this case, it's secreted by tissues near the cancer. Now, hypercalcemia malignancy is due to parathyroid hormone-related peptide. And what ends up happening is it basically acts like hyperparathyroidism. You don't have to do anything different than you would from any other form of hypercalcemia. Fluids, bisphosphonates. Fluids, bisphosphonates. And the only good thing about calcitonin is it can be used acutely to lower calcium levels. Calcitonin is a therapeutic drug. Calcitonin can be used in people who have hypercalcemia that bisphosphonates take a week to work, and calcitonin works faster. This is basically saying, how do we get calcium in and out of the bones? This is supposed to represent osteoclasts. Although for me, it's like Pac-Man. Eat, 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 eat. Well, this is osteoclasts reabsorbing that bone. Osteoclasts reabsorbing that bone. And that happens potentiated by parathyroid hormone. Osteoblasts get inhibited by parathyroid hormone. Calcitonin does the opposite. Calcitonin inhibits osteoclasts. Calcitonin inhibits the clasts and stimulates the ballasts. Now, you know what the biggest problem with traveling to other worlds is? Getting back. Well, you know, the biggest problem with us traveling to Mars, besides, I don't even want to go to New Jersey, much less Mars, is how do we stay alive long enough there in terms of our bones? That's a major problem with long-term space flight. When we get off that plane, we get off that rocket ship, we're going to be like a boneless chicken. I'm going to be like a chicken McNugget. Well, the major problem is that without weight bearing, your bones dissolve. If I wanted to set up more calcium in my bones, this is what I should do. Calcium and vitamin D, calcium and vitamin D, calcium and vitamin D, and that would make my bones hard. Calcium and vitamin D, and it responds to stress. Bones remodel, and they remodel very nicely in young people. Young means under 60. They remodel very nicely. Now, what happens when you don't have weight bearing? Bones reabsorb. Osteoclasts activate. Osteoblasts are inhibited. Calcium comes out of the bone, inhibits the parathyroid hormone. Bone is made of hydroxyapatite. Bone dissolution is hydroxyproline. Proline is what we make the gluconeogenesis from. Remember cortisol? Weight bearing makes the bones mineralize. If you don't weigh bear, then what happens is hypercalcemia happens, the PTH gets inhibited, the urinary calcium increases because you dissolve bones and it goes out in the wee-wee. The major problem with long-term space flight is that bones will dissolve and you'll be very weak when you come to the next planet. Now, excess bone demineralization. Anytime you have bone turnover, you have alk-phos that gets activated. And when you have osteoblastic activity, the alk-phos activates. That's why you get an elevated alk-phos with people who have metastasis to bone. Remember, metastasis, like osteomyelitis, dissolves and forms, dissolves and forms. Paget's dissolves and forms, dissolves and forms. That's why alk-phos goes up with osteoblastic activity as the bones are formed. You see this hydroxyproline? Hydroxyproline is an amino acid that comes out as a breakdown of collagen. How would I know if your bone is dissolving? Because it will release calcium, inhibit the PTH, the urinary calcium, and the urinary cyclic AMP goes up. The urinary calcium and the urinary cyclic AMP goes up. And hydroxyproline goes up. Now, vitamin D. 1, I take vitamin D in from the diet. 2, I get it from ultraviolet light. Diet and the light. It goes into the liver and it gets one metabolic step in the liver. It gets a second metabolic step in the tubule of the kidney. Look, this is why everybody who has renal failure has bone problems. Everybody who's got renal failure has bone problems. Everybody who's got renal failure has bone problems. And that's because when the bone is dissolved, what happens is that it's often from people who have renal failure and they don't make enough vitamin D. I thought vitamin D didn't affect the bone. Generally it doesn't. Well, why does renal failure cause bone dissolution? Because you become hypocalcemic. You become hypocalcemic because you're not making vitamin D. Renal failure, you lose 1,25-dihydroxy-D. No vitamin D, no absorbing calcium from the gut. And if you can't absorb calcium from the gut, calcium levels go down and PTH goes up. Renal failure causes hyperparathyroidism. Now, there's a unique thing about renal failure. It is the only cause of hyperparathyroidism and secondary hyperparathyroidism where the calcium and the phosphate go in opposite directions. You see, in renal failure, you get a secondary hyperparathyroidism, but the phosphate level is up. It's the only thing. Almost always, if you have a secondary hyperparathyroidism, the calcium is low and the phosphate is low because the high parathyroid hormone gets rid of the phosphate. Why can't the hyperparathyroidism of renal failure get rid of the phosphate? Because the kidneys are dead. Because the kidneys are dead. So the phosphate increases in absorption because the phosphate increases in absorption. So 24,25-dihydroxy-D is dead and inactive. 1,25-dihydroxy-D is extremely active, and that's the main thing that our kidney makes. Vitamin D is a gut hormone. Vitamin D increases the total supply into the body. Vitamin D increases gut absorption of both calcium and phosphate because that's what I need to make bone. I can't make bone if I just absorb one. I can't make it as much. So therefore, I want to absorb both calcium and phosphate to bone. I take it from the diet. I take it from the sun. There's a poem in there somewhere. From the sun and my diet, I make vitamin D. It's activated 1-step liver, 2-step kidney to the most active vitamin D, which absorbs calcium from the gut. Under pathological amounts of high vitamin D, that vitamin D will kill the bone. Under pathological amounts of low vitamin D, I reabsorb bone. So under pathological amounts, high or low, my bones are screwed. Vitamin D, here we go. Under normal conditions, vitamin D raises both calcium and phosphate. Vitamin D will increase calcium and phosphate from the intestine by absorbing both. And the high calcium and phosphate is going to make bone. I'm going to make bone. Now, the 1,25-dihydroxy-D is made at the renal tubule. And this last point is, only under conditions of abnormally high amounts will I dissolve bone. Hyperparathyroidism. A man comes for a routine office visit. He's found to have a high calcium level. He's asymptomatic. He just happens to have a high calcium found on routine screen. What's the most common cause? Hyperparathyroidism. By far, the most common cause of hypercalcemia is hyperparathyroidism. Maybe the normal values need to be reset of calcium in the country. Maybe they do. However, more common than sarcoidosis, than malignancy, immobility, hypervitaminosis D, more common than all the other causes of hypercalcemia put together is primary hyperparathyroidism. Now, the reason why it's called primary, you see this primary, is because it happens without provocation. If it had happened with provocation, we wouldn't be calling it primary. It's called primary hyperparathyroidism because it happens without provocation. What ends up happening with that hyperparathyroidism is it raises the calcium and excretes phosphate. So that's why it gets rid of the phosphate. It makes the urine calcium and also makes you urinate a lot because did you know that high calcium inhibits ADH at the kidney tubule? Did you know that hypercalcemia inhibits ADH at the kidney tubule? Did you know that hypercalcemia inhibits ADH at the kidney tubule? Hypokalemia and hypercalcemia inhibit ADH at the kidney tubule. Low potassium, high calcium, and that's why everybody with hypercalcemia gets polyuria. Now remember, urinary frequency is like cystitis. That's like urethritis. Burn, 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 frequent, 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 but not any volume. High calcium. 1, it's an osmotic diuresis. Number 2, it causes a DI, diabetes insipidus. Now, here we go again in adenoma. 1% is malignant, 15% or so is 4-gland hyperplasia, and 80% is a single adenoma. Why doesn't it inhibit the release of parathyroid hormone? Because a fundamental feature of biologic tissue is that a failure to respond to normal feedback inhibition is a sign of disease. A failure to respond to normal feedback inhibition is a sign of disease. That's why it's a disease. Oh yeah, you can get a parathyroid hormone-like particle, but it's not the same. This is the biggie. Most patients with hyperparathyroidism don't feel anything. They could get bone problem, osteoporosis, stone problem, nephrolithiasis, groan problem, abdominal pain. They can get stones, bones, moans, and groans, but most are asymptomatic. Stones, bones, moans, and groans, you're lethargic. Nobody understands why. You're depressed and fatigued because you're hypovolemic. And we don't understand the effect on mental status changes. What we do know is that when you have hypercalcemia, you got to check the parathyroid hormone first. As a matter of fact, even a normal level of parathyroid hormone with high calcium is pathologic. Even a normal level of parathyroid hormone with hypercalcemia is pathologic. If you're not fully suppressed when you have that high calcium, that's pathologic. Now, you have a high plasma calcium and a high parathyroid hormone level, that is a parathyroid hormone, primary hyperparathyroidism. What you basically do, here's the biggest issue. Who needs their parathyroid removed? Now, this is unique. If it was anything else, we'd automatically remove it. But hyperparathyroidism is so common that unless you have a stone, bone, kidney problems, we're actually not going to do anything about it. I don't have any bone problems. I don't have any kidney stones. Thank you. I don't have any mental status changes. So if I had hyperparathyroidism, you would not do anything about mine. This is unique. If you have a hyperparathyroidism, but you're not feeling anything abnormal, you don't get rid of them. Just leave it alone. You leave it alone. Now, if you have a high plasma calcium and you have a low parathyroid hormone, it's not hyperparathyroidism. You have something else that's causing your hypercalcemia. So the first thing is surgery to remove the adenoma if you have kidney stones, bone problems, psychic groans, abdominal pain. Asymptomatic hypercalcemia, leave it alone. Hypocalcemia, from hypoparathyroidism. What you're going to do with hypocalcium and hypoparathyroidism is you're going to give calcium and vitamin D. It basically happens by having your parathyroids removed from surgery. Your surgery, you have the things cut off by accident, and they're gone, and you have hypoparathyroidism. Basically, with the low parathyroid hormone, you decrease the calcium, and you have an increased phosphate, because remember, parathyroid hormone makes you increase calcium and excrete phosphate. So now you have a decreased calcium and increased phosphate. You get hypocalcemia-induced tetany. Oh my goodness, Trousseau sign, Trousseau sign. Oh, 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 oh. Trousseau, 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 Trousseau. You put your trousseau in my Trousseaux. Hypoparathyroidism leads to low calcium, high phosphate. You're hyperexcitable. You give them calcium and you give them vitamin D. Pseudo-hypoparathyroidism means that you have parathyroid hormone level that's normal, but your tissues are resistant. Period. It looks exactly like hypoparathyroidism because you have it, but it's not having an effect. It's familial, and the thing about it that's going to make you notice it is you've got a short fourth digit and you've got mental retardation. Short fourth digit, round head, mental retardation. Short fourth digit, round head, mental retardation. Looks like hypoparathyroidism. Pseudo. Short fourth digit. That's what I always think of when I think of those guys doing that, right? Pseudo-hypoparathyroidism. Now, the primary disorder means that your calcium and phosphate are changing in opposite directions. Primary hyperparathyroidism, the phosphate goes down, the calcium goes up. Primary hypoparathyroidism, the calcium goes down and the phosphate goes up. The only exception is in renal failure, the calcium is going down and the phosphate's going up, and it's the only exception. That's because the kidneys are dead. In secondaries, they should change in the same direction. In primary problems, the calcium and the phosphate should go in opposite directions. I don't have enough parathyroid hormone, my calcium drops, and my phosphate goes up because parathyroid hormone excretes phosphate, but I don't have the parathyroid hormone. Renal failure is an opposite problem. When you are deficient in vitamin D, you don't absorb enough calcium. When you don't absorb enough calcium, the parathyroid hormone level goes up. That's hyperparathyroidism secondary to low vitamin D. When you don't have enough vitamin D, you have a decrease in the plasma calcium, which leads to a rise in PTH. And the rise in PTH tries to bring up the calcium level, but it won't do it to normal. And the phosphate level will change too. The phosphate level will go down. So when you have vitamin D deficiency, the hyperparathyroidism will cause a change in bone mass. When you have low vitamin D, the parathyroid hormone level will go up and the phosphate level will drop down. Secondary hyperparathyroidism. Now, the rare person who's got either sarcoidosis or hypervitaminosis D, the calcium level will go up, which will shut off the parathyroid hormone level. And when you shut off the parathyroid hormone level, the phosphate level will go up too, because there's no parathyroid hormone level to get rid of the phosphate. Too much vitamin D, the calcium goes up, shuts off parathyroid hormone. No parathyroid hormone, nothing to excrete the phosphate. And they change in the same direction. Secondary things change in the same direction. Primary things, they go in opposite directions. Secondary things, they go in the same direction. Primary things go in opposite directions. The only exception for this is renal failure.